Okay. Test. 1, 2. Worcester, all good to go down there? The last half of this PowerPoint is really looking at the disorders themselves, and maybe taking a little bit of what we just circled around and just put it in a more purposeful direction, which is figuring out and looking at the mechanisms for a metabolic, a respiratory, acidosis, or alkalosis, or each of the four. So that's what eventually we do. And then the last section, what I did is, again, you're going to find plenty of easy reader interpretations, if you will, of acid-base balance out there, whether emergency medicine literature or any other primary care or internal medicine, whatever the case is. Everybody seems to have a summary to be able to help you attack it a little bit. But what I did was base it off that article, just kind of a little step system of identifying the disorders. And really the intent is I'd like you to be able to, at the end of this module and for the final, is to be able just to determine or recognize the primary disorders. In other words, based on the lab values, what the scenario is. Then there's a couple other things you have to identify, and then I'll leave it to ClinMed to start talking about more street life of mixed scenarios that are more likely to occur. So with that, as we said, I've run through some of the schematics, but what I'd first like to do is look at, you need to know the values. We talked about CO2 being up or down, we talked about a base being up or down, and we talked about pH being up or down. So for our purposes, what you will find clinically and lab-wise, like everything else, there's a range or a norm value. But for our purposes, we're going to kind of draw the line in the sand and use a single number to get the concept of increase or decrease and not mess around with the ranges. But appreciate there are different ranges. Obviously, pH, the 7.35 to 7.45, is kind of a normal range or what have you. So, but we'll use 7.4 for our base 24, although you'll see ranges like 22 to 28 might be numbers that people talk about clinically. But so I'm kind of putting a little asterisk here. This is that separation of theory of figuring it out versus clinical reasoning and application on the street for us. And for CO2, we'll use our 40. And again, if you think about it, remember we did our pulmonary numbers and you looked at those gradients, and it should kind of make sense where some of these numbers come from. All right. So the whole discussion, simple versus mixed. Simple really represents some disequilibrium, creating a primary disorder, if you will. And that can be either respiratory or metabolic, and acidosis or alkalosis. The only caveat is when you get down to metabolic acidosis, there's a situation where there's this anion gap that we have to address and talk about a little bit. The value in this is if, say, somebody has a respiratory acidosis, and then you can calculate and you find out there's an anion gap, that's a clue to tell you, oops, there's two things going on. This person's probably got a metabolic acidosis going along with it. So there's a few ways to kind of clue you into how to do that in theory we're going to try to walk through here. But as I said, ultimately in street life, plenty of clinical scenarios you could put 2 and 2 together to figure out how somebody's equilibrium is really a case of or a net effect of two dysfunctions going on at the same time. Essentially, a few other things to appreciate. We've talked about potassium. We talked a little bit about hypokalemia and signaling and things like that. And the only thing, my intent here is not to make the real direct connection, but to appreciate often, it's your potassium values. We talked about cardiac-wise, you're most sensitive to these potassium changes. So an acidosis or an alkalosis can wreak havoc with your potassium values or equilibrium, and that's where the person starts getting into, significant dire consequences, if you will. So that's the intent as far as this slide here. So moving on down the line, we'll discuss this in the steps, but we talked about compensation. So if I've got something wreaking havoc, if I have a respiratory acidosis, my kidneys are going to compensate to balance that. And over a period of 4 or 5 days, if I have healthy kidneys and the respiratory acidosis isn't too bad, it should be able to compensate in a predictable manner. And mathematically, you can calculate, hey, the compensation was appropriate. So for each of these conditions, when you're figuring out your ABGs, you're also figuring out, was compensation normal? And that's what the intent of this slide is simplistically, if there was normal compensation, then most likely there's only one thing going on with this person, one, respiratory acidosis or alkalosis, one primary dysfunction. If that compensation isn't what you would expect, and again, there's mathematical equations to tell you if it is or it isn't, if it comes out, and calculates that, boy, they've got a respiratory acidosis, CO2 values are this, but it doesn't make sense that their bicarbonate levels are this, that tells you, oops, something else might be going on as well. And again, that's the extent as far as we'll go. I'll leave it to ClinMed to start discussing the nuances of determining, the individual or the multiple ones themselves. So that's kind of concept number one here. All right, so looking at respiratory acidosis. For each of the conditions, you should understand what causes it. You should understand what the primary disruption is, and that primary disruption is either something with CO2 or something with the base. If you think about it on that equation, CO2 and your base values really represent how well they're managing hydrogen in the middle of all this. So for respiratory acidosis, cause obviously some kind of ventilation where you're not cranking out and blowing off enough CO2, so that's pretty straightforward. And so the primary dysfunction is elevated CO2 values. So again, if you see a pH that's decreased and you see elevated CO2 values, you start pointing towards a respiratory acidosis scenario. So essentially what's going on, too much hydrogen is accumulating just simply because of the gradient formed by the CO2, and you can't buffer it enough. So you get too much hydrogen going on. But before there's any compensation, there's no change in base. In other words, if I took a drug that limited me and I started to build up CO2 and theoretically starting to build up, hydrogen values, my kidneys haven't done anything to compensate, at that immediate moment, so to speak, to change my bicarbonate values. But eventually they kick in, there's renal compensation, and so I'm going to increase my bicarbonate to try to match this elevated hydrogen that's floating around due to this elevated CO2. So compensated picture, you're going to find the increased CO2 to begin with, but also the kidneys have elevated the bicarbonate to try to handle, again, that pH in the middle. So visually, looking at this, here's our pathology, here's our primary disturbance. Got too much CO2 floating around in the bloodstream, and eventually it's going to push the equation this way towards accumulating more hydrogens. If I've got too many accumulated hydrogens floating around, I need more base to float around to help compensate for that, and that's the role of the kidney, is to either reabsorb more or to secrete more hydrogen out. So pretty straightforward as far as the gross mechanism there. The caveat, though, as I said earlier, when it comes to the compensation, renal compensation for a respiratory acidosis or alkalosis, the kidneys are going to take about 4 days to max out. The machinery takes about 4 days to get at its best. So when you start looking at somebody in respiratory acidosis, There's also this subdivision where you have to go, is it kind of acute or is it chronic, and have the kidneys adapted or compensated enough? So in the first 2 or 3 days, there's certain values that represent what a normal kidney should do. And then after 3 days, a more chronic scenario, there's normal values of what that kidney should be able to do. So that's what I mean by quote unquote normal compensation. Was the compensation appropriate? Whoops, not sure where we went here with this. So this, I don't know if this complicates things more. I think I was just trying to visually show you the dynamics of the immediate moment and then the ongoing process of trying to increase the bicarbonate. But it isn't, day one, hour one, your elevated hydrogens floating around and elevated CO2. The mechanisms just take a little delay in action to occur. So there's some dynamics of directions going on, and I think that's what I was trying to do with this slide. So that's respiratory acidosis as far as the CO2 and bicarbonate balance. The bottom line is CO2 elevated, respiratory acidosis, bicarbonate elevates, and that's your compensated picture. And in theory, your pH should be trying to normalize with that going on as close as it can. All right, so causes, kind of pulling back, anything that's going to, should all make sense when you look at this. So anything pharmaceutically that's going to impair ventilation, respiration, anything neuro-wise, so Guillain-Barré syndrome, multiple sclerosis, ALS, polio, anything attacking the neuromuscular function of the rib cage that's not going to allow it to do what it should also has that potential as, sequential side effects of an acidosis developing. Or something obstructive. So anything that's going to impair just the physicalness of air going in and out of the lungs. So that should be pretty straightforward as far as respiratory acidosis. If you can walk your way through respiratory acidosis, then you flip it over to respiratory alkalosis, that should be easy. It's nothing more than the reverse as far as what's going on. So these next slides with alkalosis is just saying everything backwards. The only difference is, what kind of clinical causes are going to create this scenario. So as I said, for each condition, know what the primary disturbance is. And in the case of respiratory alkalosis, not enough CO2 floating around in the bloodstream. And that's usually a result of pushing it too much ventilation-wise. So you're just blowing off too much CO2. Before anything's compensated, that base or that bicarbonate level is the same. And then mechanisms kick into place to start to change your bicarbonate values to adapt to the levels of hydrogen floating around. Ugh, summer, getting there. Be patient. You guys have all been so professional this summer term. You've handled the summer term very, very well, I should say, both campuses. I appreciate the professionalism and just as I said, I joke about you guys having a vice wrapped around your head, and that's essentially what's gone on for 2 terms, really. Only 1 term to go, right? But 3rd term's good. It really starts, everybody gets excited. You start getting the thought of, okay, finally seeing clinic patients and why I started doing all this in the first place. So hang on, there is hope. So primary disturbance, recognize what it is and be able to kind of walk through the compensation pathway, but here's your visual. So again, drop in CO2 from too much ventilation going on, drop in hydrogen or elevated pH values, and associated drop as far as bicarbonate values to match. So that's, again, this is a dynamic process. Takes time, 3-4 days to max out to really get to where it needs to be in the long run. So essentially, as I said, alkalosis, everything in reverse of acidosis when it comes to the respiratory. The only difference is, if you think about it, causes, all of these, again, should make sense. High altitude and just screaming for ventilation and everything else down here. in this regards. Anemia represents, inability to transport your O2 and your CO2 and altering it that way. The causes to get there, obviously different, but you can kind of walk through the mechanisms and it should kind of make sense as to the hows and whys. So that's respiratory. So respiratory, the key for compensation, the kidneys, takes 3 to 4 days, and it can be in an acute or a more chronic respiratory situation for both acidosis and alkalosis. Metabolic acidosis. In this case, it's you got two ways to your metabolism. Your body can goof up its hydrogen balance. You can either ingest or create too much hydrogen or too much acid, or you can have something that's going to get rid of too much bicarbonate when you shouldn't. So you have a loss of base. Either one of those creates the net effect of acidosis. So the ultimate disturbance you see, though, is decreased bicarbonate. So again, when you look at your values, you got CO2 values, normal functioning lungs, those should be A-OK. You come over here, you see a bicarbonate that's dropped down, and that should indicate that you've got a metabolic acidosis going on. And that can account from either you've used up a lot of that bicarbonate, buffering this fixed acid or this produced acid that's going on, or from literally just losing the bicarbonate through some other form of pathway, kidney problem or GI tract problem or something like that. So that's the ultimate. The primary is looking at that bicarbonate. That's your clue to the metabolic ones. So the initial, as I said, this should all make sense. Compensation piece of it. Within hours, your lungs are doing what they can, and somebody in a long-term metabolic change, whether it's acidosis, alkalosis, their respiration rate, their resting respiration rate is going to be either elevated or decrease in a long-term, compensation. But that's the best you can do for it. So, looking at it briefly in the big picture of things, and the difference here is, if you think about it, when you look at the respiratory scenario, really here's your acid. That's your respiratory acid you're producing, really. So CO2 really, represents that. So this whole pulmonary ventilation system represents one form of either producing an acid or reducing acid. Meanwhile, your body's metabolism, as we said, you can alter that balance by altering your base or your acid, if you will. So there's a couple of different ways to get to this metabolic acidosis. And so based on looking at a few things will help you do that. That gap we were talking about gives you clues to it. So ways to elevate your hydrogens directly is whether it's through pharmaceutical or inappropriate metabolism, energy metabolism, or anything going on, cranking out too much internal acids eventually creates too many hydrogens floating around. Or the reverse, as we said, any kind of a GI tract or renal situation where you're just losing too much or massive amounts of base is also going to set up that imbalance. If it's the case where too much fixed acids are either being ingested or created, the bicarbonate goes down simply because it can't keep pace. So its values are down. So that's where, when you look at the primary disturbance, that's what you wind up seeing, regardless if it's this or this. That's a common theme to the metabolic acidosis. And meanwhile, CO2 hasn't changed. And that's, you really, I don't know if you can, this is more of a theoretical moment in time, because the ventilation is going to adapt pretty readily and pretty quickly. If you start to compensate to try to truly adapt for it, though, in theory, you blow off more CO2, you hyperventilate to blow it off, and off you go. So that's kind of the balance, and as I said, between these, you should be able to kind of just diagram how each situation between respiratory acidosis, alkalosis, and same thing for the metabolics. The only catch is this thing here with this gap I referred to. In metabolic acidosis, there's an anion gap that gets measured. But the truth is, it gets measured in any assessment of ABGs. So that's why as I looked at this morning, I said, I don't like the terminology where that was typed in. So I kind of put that little X there to remind us. Really, you should just look at it as either I've got an anion gap metabolic acidosis or I have a non-anion gap metabolic acidosis. So in other words, in the case of metabolic acidosis, I can develop this thing called a gap or an anion gap or an AG. Or I can have metabolic acidosis without a gap present. And each one just means a little difference of how you got there. So there's different causes of getting there that we'll take a look at it. Meanwhile, I guess I should back up. I know eventually I'm going to talk about the gap. I got a couple of slides. But essentially, the anion gap represents comparing your cations, all those positive charges, your sodiums and hydrogens, with your anions. And the major players that get measured with the anions are the bicarbonate, your base, and chloride. Those are the big ones. And under normal circumstances, there's a bunch more little anions, proteins, and other ones floating around that kind of create this, on paper, a little bit of a difference, saying, hey, there's more positives than there are negatives, and you have a quote-unquote normal anion gap form. That's a normal, healthy metabolism. It's just they simply weren't measured to make the numbers quote-unquote equal. However, when you have a metabolic acidosis, if you lose that bicarbonate, if that's the cause of it, the chlorides can make up for it. And so the anion gap stays the same. However, if I have something more like too much ingestion of a toxin or poison or any of the causes of having too much of a fixed acid put into me, the chloride doesn't make up for it, and you have an increased anion gap. So those are some of the connections, and they come out a few slides later here too to help give you the visual for it. But when you look at causes, a lot of these are all formation of that fixed acids, if you will, having too many hydrogen, a production factory for hydrogens. Meanwhile, the non-anion situations are a result of just you got, by mistake, you got rid of too much base. So that's a very simplistic, split or discussion of anion versus non-anion gap scenario. But they help give you clues as to diagnostically, why is a person in this metabolic acidosis? And then before I forget it too, the last thing is, if the person's in a respiratory acidosis or a respiratory alkalosis or a metabolic alkalosis, the other three, and there's a gap present, then that indicates, this person also has an underlying metabolic acidosis. So that's what I mean. I'm kind of set the stage for, in Clin Med, that's where all that discussion will occur. And this is kind of the basis of the background for that. That's how that gap is used with it. So the gap helps you determine what the cause of the metabolic acidosis is, or if a gap is present in a non-metabolic acidosis scenario, that also indicates a second problem of a metabolic acidosis going on. So if I haven't spun your head around three ways, we'll see what we do. So metabolic alkalosis is the exact opposite. So just like the other one, really you just have to go backwards through it. So all your increases are now decreases and vice versa. So I don't think there's really too much to chat about here, other than the same thing where artificially you've ingested or had too much bicarbonate put in, or something is causing the production of acid to be diminished. So the exact opposite mechanics, if you will, of its counterpart of metabolic acidosis. So compensation, what's the lungs ventilation going to do? Hypoventilate to obviously try to retain as much CO2 as possible. So ultimately, you're looking at the balance as far as that bicarbonate. If you've got an alkalosis situation and the bicarbonate is elevated, then that's going to point towards a metabolic acidosis scenario. So again, I don't think I need to kind of walk through each one of these. These slides kind of just visually reiterate what we were saying for each of these along the way. All right, causes. As I said, how can you get rid of acid, excessive vomiting? Besides the fluid loss, if you think about it, you're getting rid of all your hydrochloric acid and GI tract acids. You can have a change. We talked about the ECF promoting or inhibiting hydrogen secretion or inhibiting bicarbonate reabsorption, et cetera. So obviously ECF volume or status can affect that as well. And then last but not least, that whole hypokalemia and affecting, again, your ability to excrete hydrogen or not to excrete hydrogen, and part of it is through that buffering system of ammonia and the production of that buffer. So just some examples of how to get there, that's all. All right, so again, these last couple of slides just reiterate this gap discussion. So I'm not sure if I've already said what they are there, but just to reiterate, I don't want you to walk away thinking only measure anion gap if it's metabolic acidosis. It should always be assessed. And then I'll defer again to your ClinMed as far as values, et cetera, and interpreting what the findings are. But the bottom line is, with this gap, as I said, it's a balance between these cations of your sodium, which is the most prominent, floating around in your bloodstream, versus the anion of chloride in your bicarbonate. And the reality is there's a lot of other smaller proteins and peptides and other anions floating around that don't get measured. And so the difference between your normal sodium and your normal chloride and bicarbonate is a little bit, it's off by about 10, give or take. So I think that's what we'll look at are the normals here as far as ranges. So the first thing I should put out here is there is a lot of discrepancy of what the normal gap is. So appreciate when you get out there, different lab values or different clinicians might have little variations of what they use as their thresholds. The second piece of it is if a gap's present, it gives you something to help you clinically as far as diagnosing and figuring out what's going on. But again, the thresholds and the variation of the normals kind of challenges, how sensitive or how specific that clinical diagnostic piece can be. So the rule of thumb I'd leave with you is the more extreme the gap, the stronger its role in making clinical diagnosis, put it that way. So when they say, a gap means XY diagnosis, the bigger that gap is, the more oomph that, clinical deduction is, if you will. So as I said, the balance, I'll briefly give you the background. I already did this, but really the under metabolic acidosis situation, if the gap is maintained, what occurs is the chloride has compensated. There's been an increase in chloride to do that. And in general, whenever you have the loss of base, the chloride is able to make up for that neutral or electroneutrality, if you will. And so, it appears that the gap is normal. So metabolic non-anion gap is more typical of this base loss. If the metabolic acidosis is due to that whole fixed acid, too much production factory of acid, either internally or pharmaceutically or drug-wise, then the chloride doesn't make up for it. What's going on is those fixed acids are contributing their anions, and there becomes a gap form between the two. In other words, you aren't measuring all these other new anions, for lack of a better word, that come from the acids. So the bottom line is, if it's normal, think base loss. If it's elevated, think something's cranking out or production of too much acid to create the metabolic acidosis. And this slide is just reiterating what I had chatted about. We're going to use this number of 12 for our mathematical, keep it simple strategy in life here. On the slide before, I think it had a range of 6 to 16, and I bet you could probably Google or go find some other references that have different ranges too as well. But for our purposes, we're going to draw the line at, say, 12. But the point is if you've got a gap of, that's 16 or 17 or 15, that's not as strong clinically information-wise than if you had a gap of 22, 24, or 30. And so, it kind of makes sense, but I'm just kind of pointing out the fluff zone of that gap as far as the math goes. All right, so that's a little discussion of each of the disorders in of themselves, the primary cause and primary disturbance, and then understand the mechanism of compensation and how they would look for each. And then finally, this is what I put is this little 5-step program, if you will, to assess acid-base balance. And you'll find plenty out there. I happened to, dig up this article. I thought it was explained pretty decently, and I threw it out there to you for a reference. Today is Wednesday. We have a final exam next Wednesday, and I imagine you're doing a few other things in between today and next Wednesday. So what I'd like to do is kind of simplify what my intentions are here and what your expectations are for calculating acid-base balance. So we're going to give you 5 steps, but you're not responsible for all 5 steps, and I'll tell you what I mean as we go down the line. So if you were to dig through that article, and you don't have to go read the article, and I'm not going into that article to find test questions out of. I've given it to you for a reference if your head's spinning around and you just want to get some background to back up what we've yacked about today. But what I'd like you to be able to do, I'm going to give you examples, and you should be able to determine A, if it's acidic or an alkalosis situation. So that's pretty straightforward. The next scenario is you need to be able to determine is it respiratory or metabolic. So far, that's pretty easy, pretty straightforward. It's take you all 15 minutes to wrap your head around to be able to do it. And then the next 2 things you'll be responsible for is just to determine if that compensation's appropriate. Remember, we made those comments before, and clinically, the reason you're figuring out is compensation appropriate is to go, if it's appropriate, if I've got a respiratory problem and the compensation, the values look appropriate for what the kidneys are doing, then that kind of reinforces the fact I only have one disorder, that respiratory disorder going on. If the compensation's not, that mucks up the water, and you may have something else going on metabolically or respiratory-wise too as well. So to be able to figure out if the compensation is appropriate, some brilliant physiologists, mathematicians, and whoever else got together and figured out some calculated equations to say if your CO2 is this and you plug in the other values, that means it's compensated. The only caveat is each one is a little bit different. And so I have those equations, the article provides those equations, and I will have those equations printed on the test for you. You don't have to memorize them. You just have to need to know how to use them. And then finally, step 4, you just need to be able to figure out if the anion gap is present. So again, I've put that X through there because I think it's a little misnomer of, it shouldn't be saying if metabolic acidosis only. Really, in all scenarios, you should be addressing it. And then finally, step 5, don't worry about. That's code for really figure out what the big picture is if you've got complex multiple disorders going on. And so again, I'll defer to ClinMed to have any discussion there. To do all this, you need the normal values. So what I'm giving you are those values. So for our purposes, pH 7.4, CO2 40, and bicarbonate 24 are going to be the values. Keep in mind, clinically, there's ranges here, and there's ranges here. As I said, this is about 22 to 26. Clinically, as we said earlier, the range is 6 to 16, but we're going to use 12. So we're kind of artificially or simplistically just drawing the line and say, let's use a single number. So if it's increased, or if it's decreased, it's decreased. Keep it that simple. So you need to be able to have sodium values, bicarbonate values, and chloride values as well to be able to calculate it. So for an example, I would be giving you those as well. So step one, figuring out acidosis, alkalosis, that's easy. The pH value will be given to you, so you figure out which way you're going. So that's the first step in all this. And then you're going, okay, if it's an acidosis, my next challenge is this thing respiratory or is this thing metabolic? And that's pretty easy. You look at the values, and these are compensated values, but you look at the values and you're going to see elevated CO2 and elevated bicarbonate. And the one that makes sense for the acidosis gives you the clue. In other words, elevated bicarbonate wouldn't make sense for an acidosis situation. Elevated CO2 certainly does. So any situation where I have too much CO2, that represents a respiratory acidosis. And then the reverse, if I've got a diminished base from either trying to make up for buffering or a loss of base, that represents a metabolic acidosis. So once you get past this step, the next step is look at your values and look at the 40 for your baseline, 24 for your baseline, and figure out is it above or below. So that's pretty easy. And then you do the exact same thing for an alkalosis situation. So the first step's pretty straightforward. This compensated piece, this is the challenge, but the nice thing is know the concept, don't memorize the equations. I couldn't, memorize or tell you what the equations are. Truth of the matter is the computer's doing it for you anyways. This day and age it's being calculated and spit out to you, but you should understand how you get there and the whys to it. So the next step is, if I give you a clinical scenario, be able to tell me is it compensated, non-compensated. But the key is you have to have already figured out if it's metabolic acidosis or respiratory acidosis. You have to do the first two steps correctly to be able to sequence along here to figure out your compensation. So in the case of metabolic acidosis, if you're, this is where don't get wrapped up into the math piece. Just take it verbatim. Just say the expert told me so I will trust them that if this equation meets the criteria, it is or isn't compensated appropriately. So essentially, what this equation is saying is whatever your CO2 value is, so if I've got 44 or if I've got 32, whatever that value is, if I plug in my bicarbonate value and do the math, they should be equal. So essentially, you put in your bicarbonate value, multiply times 1.5, add 8, and then it should equal this CO2 value. The only catch is, way down here, it gives you a little wiggle room to say it should be close to equal, either 1 or 2 above or 1 or 2 or below. And so that's how the math piece of this is handled. Sneak down to metabolic acidosis. This one's a little different. That's what I mean. Each one of these aren't the same all the way down. What this is saying is for every increase in CO2, so now this is kind of a dynamic number, so now you have to go 40 is my normal. If my CO2 is 50, I'm now saying 10 equals this over here. So this arrow increase represents an increase of CO2, not the absolute value of CO2. So big difference as far as calculation and plugging in numbers, that's all. Then you do the math, you plug in your bicarbonate value, and same thing, 0.6 times the increase of bicarbonate. So it's the same thing again, I take that back. Not the absolute, the increase of bicarbonate. So if my bicarb is 24 to begin and it's 30 now, I have an increase of 6, and that's the number I would put in there. And again, gives you wiggle room of plus or minus 2. So if the equation comes out where this is just a little above or a little below, it's close enough. Again, kind of like Major League, double play at second base. He's close enough to the bag. So that's acidosis, alkalosis, in metabolic land. Respiratory follows a similar pattern. It's just the arrows go a little different. So you have to be able to plug those guys in. So respiratory acidosis, the compensation that should go on if I've got healthy, happy kidneys is the following. So every increase of PCO2 by 10, so it's kind of taken this in units or chunks, if you will. So if I've gone up, say from 40 to 50, I've gone up 1. And then coming down here, the increase of bicarbonate should be by 1 if it's in the early stages. In other words, the kidneys can't crank out or produce that much bicarbonate that quick, so it's only going to increase it by 1. However, after 4 days, 3-4 days, the kidneys have finally got the mechanism up to speed, and they're cranking out, reabsorption of bicarbonate and cranking out as much excretion of hydrogen as they can. That value should make sense. It's higher. So again, using that, if I've gone from 40 to 50, I've gone up by 1 unit, if you will. And if I started out at 24 as my baseline, and if I've got an increase of, say, 28, that would represent normal kidney compensation, if you will. So that's the basis behind it. And as I said, by going through this rote mechanism of doing the math, I think it'll help you, with on-the-street clinical decision making for these. Then in respiratory alkalosis, the same concept. It's just that things are going down by units, and the numbers are a little bit different. It's by 2 and 5. It's a little more challenging to do this 2 as well in the alkalosis, but again, we're kind of using the hypothetical mindset to get the basis for your clinical reasoning. But the point being, chronic, when they use the term acute and chronic, the dividing line is that 72-hour mark. So, longer than 3 days. So 4 days and on represents chronic. 1 to 3 days, 48, 72 hours represents that early acute phase, and the kidney's still ratcheting up its ability to compensate and adapt. Then finally, figuring out the gap present. Again, take a moment to cross this out because I don't think it's a little misleading. It gets the media attention with metabolic acidosis, but really in all scenarios you should be doing that. But the bottom line is, if that anion gap is present, so you'd need to know your sodium values and chloride values. So if I give you a little clinical scenario, I'm giving you the numbers and you're just plugging them in. So you just need to be able to mathematically do that. And so essentially what you're looking for, if that number is greater than this line of 12 that we were using. And as I said earlier, street version, 20 is kind of where you need at least to represent a significant change, if you will, to have some meaning, given the fact that some, values make 14, 16 a normal value. So keep in mind the difference between reality and the conceptual piece we're just trying to do mathematically. So if it's less than 12 or equal to 12, theoretically it should come out equal, but normal is 6, 8, or 10. Then you have a non-anion gap metabolic acidosis present. But the take-home message is you can DDX to some degree or have clues towards the cause of this. Again, if there's a gap present, you've increased your acids some way, artificially externally or metabolically internally. Or if you've lost your bases, then that gap is going to remain the same or neutral. It'll be made up for by the chlorides. So those are the 4 steps you need to do. Is it acidosis, alkalosis, metabolic, respiratory? Is it normal compensation? And was there a gap present? So that's your assignment if you choose to accept for the final exam when you get to a few questions on this. That's what I'm looking for to be able to take home message piece of it all. Keep in mind, the reality is you're really trying to figure out the multiple piece of it. And there's a lot of different variations that, I think if you're comfortable with the first 4 steps, will be a good platform to take off from for the street version of acid-base balance. At the very end of all this, and if you want to walk through it, the only thing I did was copy the numbers from the article. In that article, in the back, they give you 4 or 5 clinical scenarios or examples just to say.
Hey, Dr. Stoll?
Yes.
Hey, there's some questions down here, but you're not hearing us for some reason.
It's the last day. Decided to ignore you. Feeling tired. No, I'm sorry. I can't, the feedback is terrible. What do we got for questions? Barely. I'm going to start pushing buttons, but it might be trouble. Try that again.
Can you hear me?
I think good enough. Try the question, and I'll get interpreters to throw it up to me if I can.
I'll just come up here. Can you hear me?
Oh, can now. Yep.
Okay. Could you just explain in step 3, for every increase in 10, it's 1 unit for 10. So if you increase bicarb by 1, does that mean you're increasing by 10? So acute would be 10 and chronic would be 40?
Let me see if I can interpret. Let me restate it and see if that answers your question. Might be simplest here. The mathematicians figured out that there's, for every big chunk of CO2 increase, there should be an equal increase in bicarbonate. It's just that the numbers, the likelihood of increasing CO2, the numbers will be bigger. So what they said is for every 10 I go up in CO2, I'll only see maybe 1 in bicarbonate in the early time, or if the kidneys have maxed out, I might go up by 4. That's a normal kidney response. Does that answer your question? Or was that even what
so
you're...
Yeah, so going from like 40 to 50 in PCO2 and bicarb would be like 1 to 2.
Exactly. I mean, bicarb starts at 24, so you go to 25, 26, 27, 28. So, does that make sense?
Yeah, thank you.
All righty. Any other questions? And I apologize for ignoring you. I'll blame it on technical difficulties. Okay, so in summary, this last little bit is just giving you an example to hand hold through there. You have the PowerPoint. I think I was doing guided discovery in your notes and not leaving the answers where you theoretically would write them in. But the answers are in your in the article in different patterns and explanations given, and I've given you the examples here. The only thing I did change is make the student 21 years old, so they were of legal drinking age. I think in the article it said a 20-year-old. But the bottom line is, more importantly, I guess for your urgent needs, next week for the exam, I'll just give you a scenario like this. In other words, I'll give you the values. I'll give you the metabolic panel as far as sodium and bicarbonate, et cetera, and CO2 and O2's there just to keep everybody happy, but you won't be using it. But I'll be giving you an example, and you'll be asked to calculate those first 4 steps based on that example. Question?
Yes. You use a pH more than 7.4 for alkalosis. This is 7.45, right?
Yeah, that's what I was referring to earlier. Is I'm taking a little latitude and using a single number, and the reality is 7.35 to 7.45 represents your normal pH range. But for our math examples, I'm just saying let's use 7.4 so we don't have to get into the double decimals and also a range. So, yeah, it's more conceptually what I'm chasing here as far as... So, yes, absolutely.
You just said you're going to test this just a simple, acidosis, alkalosis, and compensatory, acidosis or alkalosis. Will you test this mixed acidosis?
No, the only interpretation, the only caveat is what I can be asking you. In other words, I'm asking you the first 4 steps, and you go, what do the first 4 steps tell me? Well, respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. Is compensation normal or not? If it's not, it's suggestive of mixed, but I'm not going to go in the deep black hole of, well, then if it's mixed, is it a respiratory plus a metabolic? Like, we don't have time nor place to go there, and I'll wait for your clinic. But you should come to the conclusion that if compensation is inappropriate, it's suggestive of a mixed. And the same thing for the gap. If a gap is present in a non-metabolic acidosis scenario, that also implies there's a metabolic acidosis going on in this person too as well. So that's the extent of the mixed stuff, if you will.
My question is really sometimes I have to differentiate the compensatory, acidosis or alkalosis from the mixed, like this patient have metabolic acidosis with some respiratory alkalosis. This kind of case is not uncommon.
Yeah, and that's what I'm saying is in the street world, that's what I'm deferring to your clin med discussion. So our purpose is here. I'm just kind of setting the stage when they're tossing out the different scenarios as why they've got a metabolic acidosis and why the values also represent a respiratory alkalosis going on, and they do it at 90 miles an hour. Everybody be on the same page. So that's my intent. So wander through these, but if you can calculate the first steps of these, I think it's very straightforward. So I don't think I need to handhold you through them, but I'm just giving it to you for an example. Any other questions, concerns? Just drawing in midair. Okay. Alrighty. Well, I wish you guys luck. As they say in Apollo, it's been a pleasure in traveling with you. But I've appreciated, as I said, your professionalism because I know it's not so easy. Thanks. Good luck in clinic and Worcester, as I did hope to get down there, but life's soap operas for me kind of goofed up my schedules. But it was fun getting down there. I don't like the distance as much. I like to at least see who's who at different times. So, but good luck to all of you. Hopefully I probably confused you quite a bit, these few two terms in my own logic. But the real intent is whatever you do out there clinically, just don't be a recipe clinician. If there's anything that drives you crazy out there, it's people not thinking. And that's really the intent is if you know the systems, think about the systems. Don't just rely on our information life of technology out there. So there's my little soapbox for your clinical advice. But have fun. Third term gets better. And then next year, it's where you really have fun. So good luck. Take care. Take care, Worcester.